This is a case of subtotal cholecystectomy in a patient who was on dual antiplatelet agents and had hemobilia. Now, this patient wasn't settling in the ICU. He had a count of 40,000, which came down to 24,000, and the LFTs were deranged. The patient was put up for an ERCP, which showed that after removal of the stone, there was a lot of hemobilia, and there was a drop in hemoglobin of about 2 gram percentage. Since the patient wasn't settling down, I took up the patient for surgery. And as you can see, a lot of adhesions at the superior edge of the liver, and the fundus of the gallbladder is barely seen there. Small dissection done in this area doesn't yield us the right plane, and there is colon just below it. So in order to make the surgery safer, I decided that we'll approach the gallbladder from top to take down the adhesions. However, these yielded no results, and hence I turned my attention to inferior area where we thought that there was slightly less inflammation, and there by suction dissection, feeling the gallbladder on the right side, I gently dissected the whole omentum along with the colon which was stuck to the gallbladder. And as was expected, the field was all red because the blood wouldn't clot because of the dual antiplatelet therapy. So I used a suction to, possibly this is the area where the perforation was, and I used the suction to gradually take down the omental adhesions. And these areas where there were chronic adhesions, I used a bipolar forceps to take the adhesions down. And one has to be very careful. One has to make sure that there is no colon in the area where we are dissecting. And only when we are very certain that there was no bowel, I went ahead and took the adhesion on the posterior wall gradually down. And as you will see here, step by step dissection, and here you can see the colon, just the face of it, which is now being pushed away by my left hand, and all these chronic adhesions which are there were taken down using a bipolar forceps. There are a lot of adhesions on the liver also, and I have not shown it in this video, but I have taken them down with the bipolar forceps. So once I came to the neck of the gallbladder, I found that there are still few tough adhesions which I took down with bipolar forceps. And now for the first time, I think you can make out where possibly the gallbladder neck would be, infundibulum would be. And having taken this down, now you can see the gallbladder. However, we are still not seeing the gallbladder. There's still a layer of fat over it. And so what I did was, using the suction device, after taking down all the adhesions, I took the suction device and tried to dissect here, but couldn't proceed further. So I used a bipolar forceps to just make an incision on the fat, and then using the suction, we peel down the whole fat so that we can delineate the gallbladder and then proceed with the surgery. But as you can see here, the adhesions are very tough and they refuse to come down. I am not able to hold the gallbladder as well because it is very thick and it is stuck to the underlying structures. And my attempt to dissect with the suction yielded me this area, and the callus still seemed very, very badly stuck and adherent. And for the fear that I may be damaging the underlying structures here, I thought that the best policy here would be to perform a subtotal cholecystectomy. And hence I took an incision with the bipolar in the area which was about 1.5 centimeters above the suspected cystic duct. And once I opened the gallbladder, as you can see here, there are black structures here. And what are these? So I used my 10 mm. These are not stones, so they're very soft. And after opening the gallbladder further to have a good look inside, I found that possibly all these black structures were clots which are sitting there, and they had occurred because the mucosa had necrosed, and because of the dual antiplatelet, the patient had bled inside the gallbladder and hence possibly the hemobilia. So having opened the gallbladder, I had a look at the opening where the cystic duct would be. I bipolared the inner layer of the gallbladder so that there is no residual functioning mucosa. I am now suturing the gallbladder. So we are performing a reconstituting cholecystectomy. The posterior wall of the gallbladder has been detached from back so that we can go ahead and perform a proper closure. And once this has been done, I then proceeded with closure of the whole stump. Having performed the closure well, I then proceeded with removal of the anterior layer of the gallbladder and leaving the posterior layer of the gallbladder stuck to the liver, because if we attempt to remove the posterior wall of the gallbladder, there was a good possibility that we may damage the underlying structures. And once we opened the gallbladder superiorly, now we came across the large stone which was stuck in the upper part of the gallbladder. We then bagged it into a plastic bag, removed the anterior layer of the gallbladder, leaving the posterior wall intact. And once the anterior wall has been taken down, we can then perform a suction irrigation, find out which areas are bleeding. At the same time, cauterize them with a bipolar, as well as the posterior wall which we have left behind shouldn't have any secreting mucosa on it, and hence I used a bipolar. And as a final part, I then removed the fundus of the gallbladder. I removed it in the last so that we can still have some traction at the upper part, otherwise the liver would have fallen down. And then I put in a large ADK drain, removed the specimen. At the same time, after removal of the specimen, I put in gel foam in the area that we had dissected so that there is no post-operative oozing from this area. Thank you so much for watching this video.